So if you see the treatment of the dyslipidemia, see dyslipidemia, one of the very important group of drugs that we need to give is the statins. And we have the other group of drugs, that is even the fenofibrates as well as niacin. So if you take the treatment of the dyslipidemia, the long-term relief from the dyslipidemia, it is a very important aim in the management of the coronary artery disease, right? Because the long-term relief from angina, if you want to get achieved in your patient, the treatment of dyslipidemia should be very much effective, right? Then, now this, whenever you are treating for dyslipidemia, that will also reduce the need for the revascularization, and it will also reduce the incidence of development of myocardial infarction and as well as the death of the individual. Now, how is that you can achieve the control of the lipids? See, the control of the lipids, it is being done by a combination of the management that includes the diet management, that is lifestyle modification, exercise and as well as the drugs. So by the combination of a diet which should be low in saturated and as well as trans unsaturated fatty acids. So that should be the diet in order to achieve the good lipid control, and adequate amount of the exercise. So minimum 5 days in a week of around 30 minutes of brisk exercise is very much required in order to control the dyslipidemia. And next is the weight loss. So you need to maintain the ideal BMI in order to achieve the good lipid control. Now, if you take the drugs, as I have said you, the HMG-CoA reductase inhibitors. So what are those HMG-CoA reductase inhibitors? That is the statins. Okay. So what these particular statins do? Statins, they will reduce, right? These statins, which are nothing but HMG-CoA reductase inhibitors, they will reduce the LDL cholesterol. So what is the percentage by which the LDL cholesterol can be reduced by your statins is almost 25 to 50% of the LDL cholesterol can be reduced by the HMG-CoA reductase inhibitors, that is statins. And at the same time, the statins will also increase the HDL, but not significantly. It can raise only in 5 to 9% of individuals. But the lowering of the triglycerides is another important action of the statins, that is around 5 to 30%. So the major action of the statin is on lowering the LDL cholesterol. So, and what about the lowering the triglycerides and increasing the HDL? That is being achieved by fibrates, niacin and as well as icosapentaethyl. So this fibrates, niacin and as well as icosapentaethyl, they will lower the triglycerides. And specifically if you take niacin, it will increase the good cholesterol, that is the high density lipid, right? Apart from these drugs, recently some injectable monoclonal antibodies have come to the market, and they are the injectable monoclonal antibodies against PCSK9. Even they are found to be achieving the dramatic decrease in the LDL cholesterol. So along with the statins, even this particular monoclonal antibodies have been found to have dramatic improvement in lowering the LDL cholesterol, right? So if you see this dramatic improvement in the LDL cholesterol by PCSK9 inhibitors, the efficacy of these monoclonal antibodies, it is way more high than compared to that of the statin alone, or the efficacy is way more high when you give a combination of statin plus ezetimibe. So the efficacy of these monoclonal antibodies, which are like injectable agents which have been recently introduced, the efficacy is much more than compared to that of the statins alone. Okay, so this is how you need to control the dyslipidemia. And very important is the controlling the ischemic heart disease or risk reduction in women with ischemic heart disease is also very important. So if you take the risk reduction in women with ischemic heart disease, as such, if you take the incidence of the clinical ischemic heart disease in premenopausal women, it is low. Why is that? That is because of the presence of the estrogen, which has anti-atherogenic property, right? Whereas after the menopause, the atherogenic risk increases because the estrogen level reduces, so that anti-atherogenic property is being lost. So the atherogenic risk factor increases. Okay, so basically once there is decrease in your estrogen, what will happen to the LDL level is the LDL level increases, right? And thereby, if you take the number of events of ischemic heart disease in postmenopausal women, it is almost equivalent to that of men. Right, in postmenopausal women, the number of ischemic heart disease events are almost equivalent to that of men. Okay, and very important thing that you need to control in women is the diabetes mellitus, because diabetes mellitus, it is more common, comparatively more common in women rather than men. So diabetes, which is more common in women, it greatly increases the occurrence of the clinical ischemic heart disease. Right, and not only that, this particular diabetes will also amplify the deleterious effects of the hypertension, will amplify the deleterious effect of dyslipidemia, and will also amplify the deleterious effects of smoking. So control of diabetes mellitus is very, very important in women who are at risk of the ischemic heart diseases. Right, next, now the another important point is the cholesterol lowering agents. Then the beta blockers, right, along with the cardiac catheterization or revascularization. So all these three can benefit the females with ischemic heart disease. Okay, cholesterol lowering agent like statin, beta blockers after the myocardial infarction, and the revascularization in the form of PCI or CABG, right? These combined treatment is very much beneficial in females with ischemic heart diseases. Okay, and you need to understand what are all the various forms of the other drugs that you need to give in patients with the ischemic heart disease, mainly to reduce the angina pectoris. So if you take the pharmacotherapy for the ischemic heart disease, what is it designed in a way? It is designed in a way to reduce the frequency of the anginal episodes. It will reduce the incidence of myocardial infarction, and this pharmacotherapy will also reduce the coronary death in the individual. So this is how the pharmacotherapy for ischemic heart disease is being designed. Now, first and foremost, the anginal episodes. So how can you reduce this anginal episodes? We have a list of drugs. Out of that, nitrates are the very important group of drugs. And which form of nitrates do we give? That is the organic nitrates. They are of a valuable class of drugs in the management of the angina pectoris. Now, how is it? What is the mechanism of action of this particular nitrates? See, these organic nitrates, whenever they are metabolized, they release the nitric oxide, right? And this particular nitric oxide, it will bind. Okay, it will bind to guanylyl cyclase. Where is this guanylyl cyclase present? It is present within the smooth muscle of the vasculature. Okay, it will bind to, so it binds to guanylyl cyclase in vascular smooth muscle. So once it binds to the guanylyl cyclase in vascular smooth muscle, that will lead to increase in the cyclic GMP levels. Now, once there is increase in the cyclic GMP levels, that will further cause the relaxation of the vascular smooth muscle. So once there is relaxation of the vascular smooth muscle, there will be vasodilatation. Once there is vasodilatation, there will be increased perfusion to the coronaries. Okay, so that is what is the mechanism. Once there is increased myocardial perfusion because of coronary artery vasodilatation, the anginal episodes will be reduced, right? Then next important effect of the nitrates is the nitrates, they also have antithrombotic activity, right? It also has antithrombotic activity. How? By nitric oxide dependent activation of platelet guanylyl cyclase. So the antithrombotic activity is by the activation of guanylyl cyclase within the platelets, right? And not only that, this particular nitrates will also cause the impairment of the intraplatelet calcium influx. So once there is impairment of the intraplatelet calcium influx, there will be also impairment of the platelet activation. So once there is impairment of the platelet activation, the aggregation of the platelets and formation of the primary plug does not occur, and thereby it is also having the antithrombotic effect. Now, this particular nitrates, right, it will reduce the anginal episodes. It will cause the coronary artery vasodilatation. But all these in what is the way of mechanism? How it will reduce the anginal episodes? One we have discussed, one mechanism is it will increase the coronary artery vasodilatation, and thereby it will increase the myocardial perfusion. Now, what are the other ways by which the nitrates can reduce the angina? So, nitrates, if you see their action, it will cause the systemic venodilatation, right? And once there is systemic venodilatation, what will happen? The venous return reduces. Once the venous return reduces, there will be decrease in the LV end diastolic volume, right? And there will be also decrease in the LV end diastolic pressure. So, what happens here is the left ventricular wall stress, right? What happens here is the left ventricular wall stress will be reduced, and thereby reducing the myocardial wall tension and as well as the oxygen requirement. So once the myocardial oxygen tension or stress is reduced, the myocardial oxygen demand is also reduced. And another thing, so that is one way by which it will relieve the anginal episodes. And next is, it will also cause the dilatation of the epicardial coronary vessels. So thereby what will happen to the blood flow to the coronaries? So there will be increased blood flow in the coronaries and as well as the collateral vessels, and thereby there will be reduction in the anginal episodes. Now, if you take this particular nitrates, we have the various forms of nitrates which are available in the treatment of the ischemic heart disease. I'll just show you a table which is directly from Harrison, right? So, if you see this table here, like these nitrates, we have the isosorbide dinitrate and isosorbide mononitrate, that is 5-mononitrate. And what are the various ways by which the nitrates can be supplemented to the patient? So it can be in the form of ointment, transdermal patch, sublingual tablet, or the spray. Now, the question that can be asked is, whenever you are giving this nitroglycerin in various formulations, which is the formulation by which there will be quick absorption of the nitroglycerin? So whenever you are giving it as the sublingual tablet, right, then the onset of action will be quick. And if the anginal episodes does not reduce with sublingual formulation, remember, up to 3 doses 5 minutes apart can be supplemented. And what will be the sublingual dose? That is 0.3 to 0.6 milligrams. And the other routes by which the nitrates can be given is the ointment, that is dosage of 0.5 to 2, right? 2 to 3 times daily can be applied. Transdermal patch, that is at a dosage of 0.2 to 0.8 milligrams per hour every 24 hours, and remove at bedtime for nearly around 12 to 14 hours. And the other way is by the spray. Okay. And this isosorbide dinitrate, if you see, it is the only oral formulation, whereas the 5-mononitrate, it also has the oral and as well as the oral sustained release formulations as well. But whenever you are supplementing the nitrates, one point you need to understand is to prevent the development of tolerance. So in order to avoid the development of tolerance with nitrates, what you need to do is a 10 to 12 hour nitrate free interval is very much recommended in order to reduce the nitrate tolerance. Okay, right. Now, so if you just see the absorption through which route the absorption is rapid, the absorption of these agents is rapid and complete whenever it is given through the mucous membrane. Okay, so the absorption is quick when it is administered where it can be absorbed through the mucous membrane. So like that is the reason why in order to have the rapid absorption, what did I tell you? In order to achieve the rapid absorption, right, the route by which you should administer is the sublingual route, and the dosage is 0.4 to 0.6 milligrams. And patients with angina should be instructed to take the medication both to relieve the angina, that is one thing, and another area where the individual has to take this particular nitrates is 5 minutes before the activities that will induce the anginal episodes. Right, that will induce the anginal episodes. So during both of these scenarios, the nitrates can be taken by the patient, and that is what need to be instructed to the patient as well. And this particular nitrates, the effect is they improve the exercise tolerance. Why? Because it is causing coronary artery vasodilatation. So myocardial perfusion increases. So once the myocardial perfusion increases, the cardiac output increases. Okay. So it improves the exercise tolerance in patients with the chronic stable angina, right? And this nitrates will also relieve the ischemia in patients with unstable angina, right? It will relieve the ischemia in unstable angina, and as well as these particular nitrates are very much useful in the treatment of the Prinzmetal angina as well. So in case of the Prinzmetal angina, nitrates, they are considered as the drug of choice. Right? Whereas for chronic stable angina, the drug of choice is beta blockers. But again, if the question is asked, what is the drug of choice to relieve the acute episodes of angina in chronic stable angina as well? That will be again the nitrates. Okay. Now, whenever the patient is on nitrates, a diary of the anginal episodes and the number of time the individual is taking this nitroglycerin, that has to be maintained. Okay. So this particular diary, it will detect the frequency of the anginal episodes, right? And it will also detect the severity of the anginal episodes or threshold for the discomfort. Okay. So if the number of the episodes or if the frequency is more, if the severity is more, that tells that these patients with chronic stable angina, they are going into a state of the unstable angina. Right? And these further go into a state of the myocardial infarction. So the purpose of maintaining this particular diary is in order to see, is there any progression of this underlying ischemic heart disease, right? Then you take this long-acting nitrates. So what you have to remember is that which is more efficacious in relieving the angina? Is it long-acting nitrates or the sublingual nitrates? So remember, it is the sublingual nitrates. They are highly efficacious in reducing the anginal episodes than compared to that of the long-acting nitrates. Okay. And what will be the route of administration of these long-acting nitrates? So they can be oral. So oral, they can be either swallowed, right? They can be either chewed, or they can be also administered in the form of patch, or they are also administered in the form of the ointment, that is paste. Okay. So this patch and as well as paste, that will be transdermal route, right? That will be transdermal route. And these long-acting nitrates, remember, for how long they remain within the plasma? They provide effective plasma levels up to 24 hours. Right, up to 24 hours, but therapeutic response is highly variable. And if you take the side effects of these long-acting nitrates, the side effects include, one is headache, and another important adverse effects include the dizziness. So headache and as well as dizziness, these are the adverse effects of the long-acting nitrates. Okay. And so in order to avoid these particular side effects, the individual dose titration is very, very important, mainly to prevent this particular side effects. Okay. So, and one more important thing, what did we just discuss? In order to minimize the effect of the nitrate tolerance, the minimum effective dose should be used. That is one point, that is in order to reduce the nitrate tolerance, and minimum 8 to 10 hours drug-free interval has to be maintained. Okay. So minimum effective dose, then 8 to 10 hours of drug-free interval has to be maintained. That is mainly to minimize the effect of the nitrate tolerance. Okay. So that is about the story related to the nitrates. And the next important group of drugs are the beta blockers. These beta blockers, they are considered as the drug of choice in patients with the chronic stable angina. And that particular beta blockers that we give is mainly the cardioselective beta blockers. Okay. So these drugs, they represent an important component of the pharmacological treatment of the angina pectoris. So what they basically basically do? So they reduce the heart rate. So they are negatively chronotropic. Thereby what will happen to the myocardial oxygen demand? See, these beta blockers, they reduce the myocardial oxygen demand by inhibiting increase in the heart rate. Okay, and not only that, these beta blockers will also inhibit the increase of the arterial pressure, right? And they also inhibit the myocardial contractility, which is caused by the catecholamines. So all these are mediated by catecholamines. So these beta blockers, what they do, they neutralize the effect of the catecholamines, and thereby they inhibit the increase in heart rate, arterial pressure, and as well as the myocardial contractility. And these particular beta blockers, they reduce these variables most strikingly during the exercise. Okay, the efficacy of beta blockers of inhibiting increase in heart rate, inhibiting the increase in arterial pressure, inhibiting the myocardial contractility is mainly during the exercise, but causes only small reduction at rest. So at rest, the beta blockers efficacy on the heart is less. So basically what the beta blockers do, they will neutralize the effect of the catecholamines. When will the catecholamines released into the circulation? That is mainly during the exercise. So that is the reason why it has a minimal effect on the heart during rest, right? But very good efficacy whenever the individual is doing exercise or any condition wherever there is increase in the sympathetic activity, right? Now, if you take the formulations of the beta blockers, we have long-acting beta blocker drugs or the sustained release formulations. Now, what is the advantage of this sustained release formulations or long-acting? The advantage is once daily supplementation will be enough, right? Once daily supplementation will be enough. And the therapeutic aim of giving beta blocker is, that is mainly to reduce the angina and as well as to reduce the ischemia. Okay, so these will be the therapeutic aims of giving the beta blockers. And very important effect of the beta blockers is they reduce the mortality, right? And they also reduce the reinfarction rates. So they reduce the mortality and they will also reduce the reinfarction rates in patients after the myocardial infarction, right? After myocardial infarction. Okay, and whereas the antihypertensive effect is in moderate effect. Okay, so they have moderatively effective antihypertensive agents, but they have very good effect in reducing the mortality and reducing the reinfarction rates in patients after the myocardial infarction. So if you take these beta blockers, which beta blockers are preferable? Mainly the cardioselective beta blockers. And among these cardioselective beta blockers, that will be metoprolol and as well as the bisoprolol. So these are the cardioselective beta blockers. So particularly we need to concentrate on giving the beta 1 blockers. And apart from this, we have many other cardioselective beta blockers. I'll just show you a table directly from Harrison. So if you see this particular table here, right? So the acebutolol, atenolol, bitoxolol, bisoprolol, then esmolol. These are cardioselective beta blockers with AB. Then labetalol, it is both alpha plus beta blocker. Metoprolol, this is the one, that too metoprolol succinate. That is the drug which we use very commonly. Then nadolol, it is not selective beta blocker. Nebivolol at low doses. These are the cardioselective beta blockers which are very much preferable in the treatment of the chronic stable angina, and preferably which formulation among these we give is the metoprolol. So if you see the metoprolol, it is a beta 1 selective agent, right? And does it have any partial agonistic activity on beta 1 receptors? No. And the dosage is 50 to 200 milligrams twice daily. That is what is the dosage of the metoprolol, and that too we give metoprolol succinate. But you have to understand that these beta blockers, they have some contraindications, mainly in patients with pulmonary pathologies, mainly in patients with bradycardias, mainly in individuals with AV nodal disturbances, patients with Raynaud's phenomenon, patients with peripheral arterial disease. So the contraindications of the beta blockers are pulmonary pathologies like asthma and reversible airway obstruction in patients with chronic obstructive lung disease. So these two are the pulmonary pathologies where we avoid giving beta blockers. And next is atrioventricular conduction disturbance, severe bradycardia. Please don't give beta blockers, that will further precipitate the bradycardia. And vascular pathologies where we need to give beta blockers are Raynaud's phenomenon and the history of the mental depression, we should not give these beta blockers because the beta blockers, they are associated with slight amount of the depression. So beta blockers, they should be avoided. So these are the contraindications for the beta blockers, and they are not absolute contraindications, because what we are giving is the beta 1 selective beta blockers. So these are the relative contraindications for the beta blockers. And if you take the adverse effects with the beta blockers, they cause fatigue, and as well as they will also reduce the exercise tolerance. So why is that they cause the fatigue? Is because they are negatively chronotropic. The heart rate reduces, the cardiac output reduces, so thereby the individual can have fatigue and as well as reduction in the exercise tolerance. And these beta blockers, they can cause nightmares and as well as the impotency, cold extremities, and as well as the intermittent claudication. That is the because it is associated with causing intermittent claudication, that is the reason why patients with Raynaud's phenomenon, you should not give the beta blockers. And next is the bradycardia and as well as impairment of atrioventricular conduction, because it will block the beta 1 receptors and thereby the chronotropicity will not be there. And the another important side effect is you should not give these beta blockers in cases of acute decompensated heart failure. Okay, mainly in patients with class 4 NYHA, don't give beta blockers. They will further precipitate the ongoing left ventricular failure. And mainly non-selective beta blockers, they also can precipitate the underlying bronchial asthma, and they will also cause worsening of the claudication and as well as the intensification of the hypoglycemia. So these are the side effects of the beta adrenergic blockers, but these side effects are more common with non-selective beta blockers rather than the cardioselective beta blockers. Okay, now whenever you are reducing or whenever you are withdrawing the beta blockers, because you have seen the adverse effects of the beta blockers and the patient has developed that adverse effects, don't withdraw the beta blockers abruptly. So how should we withdraw the beta blockers? Reducing the dose of beta blockers or even discontinuation may be necessary whenever the individual develops the adverse effects with the beta blockers. But very important point is, sudden discontinuation, it can intensify the ischemia, right? It can intensify the ischemia. So that is the reason why the doses, they should be tapered and stopped, right? They should be tapered over 2 weeks and then they have to be stopped. And which particular beta blockers I have said you, that is cardioselective beta 1 blockers, they are the one which has specificity to the beta 1 receptors. Okay, and mainly that is your metoprolol. Another important drug is the atenolol. So these are the preferable in patients with mild bronchial obstruction. See, if you want to give beta 1 blockers, but there is some mild bronchial obstructive pathology like asthma, the beta blockers that can be preferred is the metoprolol or the atenolol. Okay, so this is about your beta adrenergic blockers. Then the other group of drugs that can be given in the treatment of chronic stable angina is the calcium channel blockers. But you have to remember one important point is that these calcium channel blockers should not be given if the individual has the features of the heart failure. Okay, because the calcium channel blockers, they further precipitate the heart failure. So now, what is the effect of the calcium channel blockers? They are the coronary vasodilators. So thereby what they will cause, they will improve the coronary perfusion, right? And these calcium channel blockers, they will also cause reduction in the myocardial oxygen demand. They will also cause decrease in the myocardial contractility, and they will also cause decrease in the arterial pressure. So thereby, what is the efficacy or outcome of these particular calcium channel blocker? The outcome of these calcium channel blockers is that the individual will have reduction in the anginal episodes and there will be improvement in the exercise tolerance. Okay, so these combined pharmacological effects are advantageous and make these agents as effective as beta blockers in the treatment of the angina pectoris. So it will reduce the myocardial oxygen demand, it will reduce the contractility, and it will also reduce the arterial pressure. See, by reducing the arterial pressure, the afterload on the heart will be reduced. Okay, and when these particular calcium channel blockers should be given, are they given as first line? No. So they are indicated when beta blockers are contraindicated. So when beta blockers are contraindicated, where you cannot give beta blockers, there we give calcium channel blockers. Okay, or the place where the beta blockers are poorly tolerated, or the place where the beta blockers are ineffective, there we give this calcium channel blockers. And these calcium channel blockers, if you see, we have two groups of drugs. One is dihydropyridine and as well as non-dihydropyridine calcium channel blockers. See, these non-dihydropyridine calcium channel blockers, example like what we have is diltiazem and as well as the verapamil. And dihydropyridine calcium channel blockers, that includes the amlodipine, cilnidipine, nifedipine. These are your dihydropyridine calcium channel blockers. Now, if you take these both group of drugs, there is difference in dose response relation on the cardiac electrical activity. So, the non-dihydropyridine calcium channel blockers, they are the AV nodal blocking agents. Okay. So, this verapamil and as well as diltiazem, they can produce the symptomatic disturbances in cardiac conduction. So, they can produce the decrease in the heart rate. They can cause the bradyarrhythmia. They can disturb the cardiac conduction. Which one? The non-dihydropyridine calcium channel blockers. But whereas these dihydropyridine calcium channel blockers, they mainly reduce the blood pressure of the individual. So, they will not cause the symptomatic electrical disturbances. They don't cause the bradyarrhythmias. Which one? The dihydropyridine calcium channel blockers. So, first if you take the non-dihydropyridine calcium channel blockers like the verapamil and diltiazem, they have negative inotropic action, right? They reduce the contractility, and that is the reason why there is high chance that these non-dihydropyridine calcium channel blockers, they aggravate the left ventricular failure. Okay, so that is the reason why these non-dihydropyridine calcium channel blockers should not be given if the patient is having left ventricular dysfunction. Okay, if the patient is having left ventricular dysfunction, please avoid giving non-dihydropyridine calcium channel blockers. Okay, and these drugs have to be avoided at the same time when the patient is also taking the beta-1 blockers. Okay, so these beta-1 blockers and as well as non-dihydropyridine calcium channel blockers, both of them, they should never be combined. They should never be combined. Okay, right. Then, if you take this calcium channel blockers, beta blockers and nitrates, they together, see, if at all, if you want to combine calcium channel blockers with beta blockers, which calcium channel blocker can be combined? That is dihydropyridine calcium channel blocker can be combined. Okay, so when you give these three in combination, calcium channel blockers, beta blockers and nitrates, they are very much essential in treating the angina in patients with the chronic stable angina. Okay, but don't combine non-dihydropyridine calcium channel blockers with the beta blockers. Okay, next, if you take this calcium channel blockers, what are the other types of ischemic heart disease where you can give this calcium channel blockers? So, you take the Prince metal angina, which is also called variant angina. They also respond particularly well with the calcium channel blockers. Especially which particular group of calcium channel blockers we give for the Prince metal angina? That is again dihydropyridine calcium channel blockers. Right? But which are considered as drug of choice in patients with Prince metal angina? Drug of choice will be the nitrates. The alternative drugs will be the dihydropyridine calcium channel blockers. So, let me just give you a table of dihydropyridine and as well as non-dihydropyridine calcium channel blockers. So, this table is directly from the Harrison. So, we have dihydropyridine, that is amlodipine, felodipine, isradipine, nicardipine, nifedipine and as well as nisoldipine. And non-dihydropyridine calcium channel blockers are diltiazem and as well as the verapamil. So, this particular diltiazem and verapamil, they should not be given in patients with left ventricular dysfunction because they can precipitate the underlying heart failure. So, if ejection fraction or if it is either heart failure with preserved or reduced ejection fraction, whatever the type of left ventricular dysfunction is there, you should not give this diltiazem and as well as verapamil. And the drugs which will be very much effective that can be given along with the beta blockers will be your dihydropyridine calcium channel blocker, that is amlodipine, can be given, right? So, the duration of action of this amlodipine, it's a long-acting calcium channel blocker, and the adverse effects of these include the headache and as well as the pedal edema. So, this is about your calcium channel blockers. And one point you should remember is that regarding the verapamil, as I have said you just now, it should not be combined. Okay, so these are considered to be the deadly combination. verapamil should not be combined with the beta blockers because of the combined adverse effects on the heart rate, because beta blockers will also reduce heart rate and verapamil also will reduce the heart rate, and combined effect on the contractility as well, because beta blockers will also reduce contractility and as well as verapamil also will reduce the contractility, right? Whereas what about the diltiazem and as well as beta blockers? Diltiazem can be combined with beta blockers in patients with normal left ventricular function, and when there is no conduction disturbances, then your diltiazem and as well as beta blockers, they can be combined. But when there is left ventricular dysfunction or whenever there is conduction disturbances, this non-dihydropyridine calcium channel blocker should never be combined with the beta blockers. Okay, and if you take this dihydropyridine calcium channel blockers, that is amlodipine and as well as the beta blockers, they have the complementary action. What is that complementary action? Complementary action on the coronary blood supply, right? Complementary action on the coronary blood supply, and thereby it will improve or it will reduce, okay, thereby the myocardial oxygen demand is being met, right? Thereby the myocardial oxygen demand is being met. So that is what is the advantage of combining the amlodipine with the beta blockers. They have the complementary action. So if you take this amlodipine, what it does, it will decrease the blood pressure and it will cause the dilatation of the coronaries. That is the effect of the amlodipine. Whereas the beta blocker, it will reduce the heart rate and it will reduce the contractility, and thereby whenever you combine these two drugs, there is the complementary action of reducing the myocardial oxygen demand, right? And next is this amlodipine and as well as the second generation dihydropyridine calcium channel blockers. Which are your second generation dihydropyridine calcium channel blockers? That includes nicardipine, then isradipine, and then long-acting nifedipine, then felodipine. Okay, so nicardipine, isradipine, nifedipine, and as well as felodipine. These are the second generation dihydropyridine calcium channel blockers. So amlodipine and as well as second generation dihydropyridine calcium channel blockers, they are the potent vasodilators, right? And they are useful in simultaneous treatment of angina, right? They can reduce the anginal episodes and they will also reduce the blood pressure of the individual. So thereby it is used in the treatment of the hypertension. Okay, whereas you take the short acting dihydropyridine calcium channel blockers, they should be avoided because of the risk of precipitating the infarction. So short acting dihydropyridines, they should be avoided. Long acting dihydropyridine calcium channel blockers, they can be given. Now, if you take the choice in between the beta blockers and calcium channel blockers, so choice between the beta blockers and calcium channel blockers for the initial therapy. Now, in which scenarios actually the drug of choice is beta blockers, but in which scenarios calcium channel blockers are indicated? Let me tell you. So the condition where the calcium channel blockers are preferred is whenever there is inadequate response to the combination of the beta blockers, right? You are giving the combination of beta blockers and as well as you are also giving the nitrates. So when you are giving this particular combination but still there is inadequate response, then to this we need to add the dihydropyridine calcium channel blockers. That is one area where calcium channel blockers are indicated. Number two, adverse reaction to beta blockers, like the patient having depression, please avoid giving the beta blockers. Patient having fatigue, please avoid giving beta blockers. Patient having sexual disturbances, please avoid giving beta blockers. So in such case, you give calcium channel blockers, right? And if the individual is having respiratory pathology, usually the beta blockers are avoided. Angina and history of asthma or chronic obstructive, so that means along with angina, there is history of asthma or chronic obstructive pulmonary disease, avoid giving beta blockers, preferably give the calcium channel blockers. And the another scenario is if the patient is suffering with sick sinus syndrome, or if the individual is having significant AV nodal conduction disturbance, there we need to give calcium channel blockers. And next is the presence of the Prince metal angina. Rather than giving beta blockers, calcium channel blockers are being preferred. And in patients with symptomatic peripheral arterial disease, beta blockers should be avoided. They will precipitate the underlying Raynaud's phenomenon. So here also calcium channel blockers should be given. So the scenario where calcium channel blockers should be given is whenever there is inadequate response, adverse reaction to beta blockers are there, and having associated pulmonary pathologies, having sick sinus syndrome, having Prince metal angina and symptomatic peripheral arterial disease, preferable to give calcium channel blockers rather than the beta blockers. And next important, so this is about nitrates we have discussed, beta blockers we have discussed, and then the calcium channel blockers we have discussed. So these are all considered under the anti-anginal, and they will also reduce the myocardial oxygen demand, right? Now let me summarize the drugs which are used in case of the chronic stable angina, that is the ischemic heart diseases. So in case of the ischemic heart disease, particularly in case of chronic stable angina, the drug of choice is the beta blockers. Now, what are the other drugs that we give apart from the beta blockers? The other drugs are the nitrates. Nitrates, they are usually given mainly to suppress or to reduce the angina. And if the beta blockers are contraindicated in certain clinical scenarios, we give calcium channel blockers. And for chronic stable angina, the drug which is being given is the ranolazine. So, first of all, you take few important points about the nitrates. Nitrates, they are available as the short and as well as the long-acting nitrates. And what are the adverse effects of these particular nitrates? Because nitrates, they are associated with fall in the blood pressure because they cause vasodilatation. The individual can have the adverse effects like hypotension and as well as reflex tachycardia. And another very important hematological complication that can be associated with nitrates is methemoglobinemia. And the other adverse effects are the headache and as well as the flushing. So these are the common side effects associated with nitrates, that is either of your short and long acting nitrates, but particularly with long acting nitrates. Now, what are the contraindications for nitrates? Remember, nitrates are absolutely contraindicated in case of the hypertrophic cardiomyopathy. And if you give nitrates in patients with hypertrophic cardiomyopathy, the chest pain in hypertrophic cardiomyopathy further increases because the nitrates, they decrease the venous return and they will increase the obstruction in patients with hypertrophic obstructive cardiomyopathy. That is the reason why they are avoided in HOCM. Now, what are the very important potential interactions? Remember, you should not give these nitrates along with the phosphodiesterase inhibitors like sildenafil because they have or they will have, if they are taking both of these drugs, nitrates and as well as phosphodiesterase inhibitors, they will have significant hypotension and they can have cardiovascular collapse. So please remember, whenever you are giving nitrates, avoid giving the phosphodiesterase inhibitors, that is sildenafil or the similar agents. And you should also not give the beta adrenergic blockers and as well as the calcium channel blockers. But beta blockers and calcium channel blockers, whenever you are giving along with nitrates, you need to monitor the blood pressure. And if the blood pressure is more than 90 millimeters of mercury, so in low dose, the beta blockers can be given depending upon the clinical scenario. But the phosphodiesterase inhibitors like sildenafil and as well as the similar drugs are like vardenafil and as well as tadalafil. They should be absolutely avoided. So that is about your nitrates. The next important is the beta blockers. So beta blockers, they are considered as the drug of choice for the chronic stable angina. Now, what are the common adverse effects associated with the beta blockers? These beta blockers, they are associated with one of the very important psychiatric abnormality, that is depression. And these beta blockers will reduce the heart rate. So the individual may land up in the heart block, that is bradycardia. And very important is these beta blockers, particularly non-selective beta blockers, should be avoided in respiratory disorders because these non-selective beta blockers, they block both beta 1 and as well as beta 2 receptors, and thereby the individual will have the bronchospasm where there will be precipitation of the underlying respiratory pathology. The other adverse effects include the peripheral vasoconstriction, postural hypotension, impotency, and masked signs of the hypoglycemia. So these are the potential adverse effects associated with the beta blockers. And if you observe the contraindications, so remember, you should not give these drugs in those individuals who are having the low heart rate or bradycardia. Please avoid giving these beta blockers. And very important contraindication is the respiratory pathologies. Like in COPD patients and as well as bronchial asthma, we avoid giving these beta blockers because they may precipitate the bronchoconstriction. And another important contraindication is because they are associated with the peripheral vasoconstriction. That is the reason why in those individuals who are having severe peripheral vascular disease, these beta blockers, they are contraindicated, right? Then followed by that, the other contraindications include like cardiogenic shock. So these, because in cardiogenic shock, the blood pressure is less than 90 millimeters of mercury. And when you give these beta blockers, they may further cause fall in the blood pressure. They may precipitate that cardiogenic shock. That is the reason why the beta blockers should be avoided. And another important contraindication is in patients with acute left ventricular failure causing pulmonary edema, the beta blockers are contraindicated. Okay. Now, what will be the potential drug interactions? So, any other drug which is causing decreasing in the heart rate, you should avoid giving beta blockers along with them. Like for example, you take non-dihydropyridine calcium channel blockers, that is diltiazem as well as verapamil. Both of these drugs will reduce the heart rate. So when you give beta blockers along with non-dihydropyridine calcium channel blockers, there will be further fall in the heart rate or they'll have significant bradycardia. So avoid giving with the non-dihydropyridine calcium channel blockers and as well as the sinus node or the AV conduction depressors. Okay, that was some important points related to the beta blockers. The next important group of drugs are the calcium channel blockers. This calcium channel blockers, we have non-dihydropyridine and as well as dihydropyridine calcium channel blockers. Non-dihydropyridine calcium channel blockers are diltiazem and as well as verapamil, and the adverse effects will be similar to that like what you see with the beta blockers. They will cause bradycardia, they can cause the heart block, and very important is they will also reduce the ejection fraction of the individual. So that is the reason why these non-dihydropyridine calcium channel blockers should never be given in individuals with heart failure with reduced ejection fraction, right? And the other adverse effects are these non-dihydropyridine calcium channel blockers, they will also suppress the gastrointestinal motility resulting in constipation. And then the individual will also have gingival hyperplasia. So these are the adverse effects. Then next to that, like what are the contraindications for non-dihydropyridine calcium channel blockers? In cardiogenic shock, absolutely contraindicated. And in case of the severe aortic stenosis and as well as the obstructive cardiomyopathy, please don't give this non-dihydropyridine calcium channel blockers. Okay, right. And then followed by that, the drug interactions are you should not give this non-dihydropyridine calcium channel blockers along with this digoxin, simvastatin, and as well as the cyclosporin. Okay, so that is about the heart rate lowering agents of your calcium channel blockers. Dihydropyridine calcium channel blockers, like usually we use rarely in cases of the chronic stable angina or ischemic heart disease. But what will be the adverse effects when the individual is taking this dihydropyridine calcium channel blockers, that is amlodipine, cilnidipine and all? They are associated with the headache, and very particularly this amlodipine is associated with the ankle swelling, and the other adverse effects are fatigue, flushing, and as well as the reflex tachycardia. The contraindications will be low heart rate, that is, or if the individual is having any rhythm disorders of the heart, sick sinus syndrome, congestive heart failure, low blood pressure, please don't give this dihydropyridine calcium channel blockers, because dihydropyridine calcium channel blockers, they are significant antihypertensives, and if you give them in an individual who is already having hypotension, there will be precipitation of fall in the blood pressure of the individual. And drug interactions of this dihydropyridine calcium channel blockers is, so agents with cardiodepressant effects like beta blockers, then flecainide and CYP3A4 substrates, you should avoid giving this dihydropyridine calcium channel blockers. So that was about your CCBs. Then the drug which is used in the treatment of the chronic stable angina, what is that? That is the ranolazine. So this ranolazine, it causes the adverse effects such as the QT prolongation. Because it causes QT prolongation, the individual may go into a state of Torsades de Pointes, which is also called polymorphic ventricular tachycardia. So the individual can develop dizziness, constipation, nausea, the QT interval prolongation. Remember, this ranolazine, it is absolutely contraindicated in case of liver cirrhosis because it is metabolized in the liver and it is excreted out. So whenever there is liver cirrhosis, there can be precipitation or increase in the levels of this ranolazine. So in liver cirrhosis, please avoid giving this ranolazine. And the drug interactions is along with the CYP3A4 substrates, that is digoxin, simvastatin, cyclosporin, and drugs that prolongs the QT interval, you should avoid giving this ranolazine. Okay, so what are the drugs which will prolong the QT interval? Like you take the aminoglycosides, or you take quinolone group of antibiotics, and you take the antiarrhythmic drugs. So particularly your class 3 antiarrhythmic drugs, they prolong the QT interval. So with that particular group of drugs, you should avoid giving this ranolazine. So this is the table of the summary of the drugs used in the treatment of the chronic stable angina. The antiplatelet drugs, if you see, we have one aspirin, and the other important group of drugs will be the clopidogrel, right? That is P2Y12 inhibitors. Okay, now out of which, let us discuss about the aspirin first. So if you take this aspirin, it is an irreversible inhibitor of platelet cyclooxygenase. Because it will cause irreversible inhibition of platelet cyclooxygenase, it will interfere with the platelet activation. Okay, now by interfering with the platelet activation, these antiplatelets, they prevent the aggregation of the platelets. And what is the dosage of the aspirin that you need to supplement per day? So it has to be given through oral route. The dosage is around 75 to 325 milligrams. And whenever you give this aspirin at a dose of 75 to 325 milligrams, it will reduce the coronary event by preventing the aggregation of the platelets. Okay, so in which all forms of ischemic heart disease we give aspirin? We give aspirin in the chronic stable angina, right? We give aspirin in the unstable angina, and we give aspirin in case of the myocardial infarction. But remember, the aspirin, it should be avoided in patients with Prinzmetal angina. Very, very important point. It should be avoided with patients with the Prinzmetal angina, right? And whenever you are increasing the dosage of aspirin, the problem with the aspirin is it has dose dependent increase in the bleeding abnormality, right? Dose dependent increasing in the bleeding abnormality. Or when you increase the dose, or when you are giving this aspirin for a longer period of time, there is a high chance of the bleeding. So in order to avoid that particular bleeding tendency, what is being used these days is the enteric coated formulations are being used. And what is the dosage of these enteric coated formulations? The dosage is around 81 to 162 milligrams per day is what is the dosage of the aspirin. And this particular aspirin administration, remember, you should give this only when there is absence of the gastrointestinal bleeding, right? Should be given only in the absence of the allergy. Should be given only in the absence of the dyspepsia. Okay, so these are the scenarios. If they are not there, then we can comfortably give this particular aspirin. So next to the aspirin, the other important antiplatelet drug is the clopidogrel, which is a P2Y12 inhibitor, right? And the dosage of this clopidogrel, right? What is the loading dose that you need to give? Loading dose of the clopidogrel is 300 to 600 milligrams that we give as the loading dose, right? Whereas as the maintenance dose, the dose that we give is 75 milligrams per day is the maintenance dose that we give, right? And it is an oral formulation, and it will inhibit the P2Y12 ADP receptor which is present on the platelets. And this P2Y12 ADP receptors, they are required for the platelet aggregation. So once this particular P2Y12 ADP receptor is being blocked by the clopidogrel, the platelet aggregation does not occur, right? The platelet aggregation does not occur. So if you take the effect of the clopidogrel is almost similar to that of the aspirin, right? And where can we give this clopidogrel is, it can be substituted for aspirin if the aspirin causes gastrointestinal bleeding, if the aspirin causes dyspepsia, right? If the aspirin is causing the allergy, in such case, in the place of the aspirin, we need to substitute the clopidogrel. Okay, right. Then what about the combination? So clopidogrel, it should be combined with the aspirin, and this combination has been found to reduce the death of the coronary it has been found to reduce the death, and it has been found to reduce the coronary ischemic events in patients with the acute coronary syndrome. Now, what is the spectrum of the acute coronary syndrome? The spectrum of the acute coronary syndrome is unstable angina, then non-ST elevation MI, and as well as the ST elevation MI. So these three, they are considered as the spectrum of the acute coronary syndrome, right? And this combination will reduce the risk of the thrombus formation in patients undergoing implantation of a stent in the coronary artery. So this combination will reduce the risk of thrombus formation within the stent what you are placing with in patients with the acute coronary syndrome. Now, apart from this clopidogrel, what are the other antiplatelet agents which are the other P2Y12 ADP receptor blockers? The other alternatives are the prasugrel and as well as the ticagrelor. Even these drugs also, they block P2Y12 ADP receptors which are present on the platelets, okay, and they have been shown to be more effective than compared to that of the clopidogrel. So the efficacy, they are more effective, right? They are more effective, right, for the prevention of the ischemic events after the placement of the stent. Okay, in patients with acute coronary syndrome, they require the stenting. So whenever you place the stent, there is risk of stent thrombosis. But when you give this prasugrel and as well as ticagrelor, the efficacy is much more than compared to that of the clopidogrel in preventing the stent thrombosis. Okay, right? But the problem with these drugs is they are associated with increased risk of bleeding. That is what is the disadvantage of this prasugrel and as well as the ticagrelor. That is the reason why this prasugrel and ticagrelor we usually avoid in elderly individuals who are at increased risk of bleeding, right? So in them we give clopidogrel in elderly individuals, but whereas young individuals preferably we can give this prasugrel and as well as the ticagrelor, right? Then you take this DAPT. For how long you need to give the dual antiplatelet drugs? So the combination of aspirin and as well as clopidogrel, the studies have been shown they have to be supplemented for at least 1 year in patients with acute coronary syndrome who had undergone the implantation of the drug-eluting stent. For 1 year you need to give, okay? And studies have not shown any benefit from routine addition of the clopidogrel to aspirin in patients with chronic stable angina. So, dual antiplatelet therapy, is it required in chronic stable angina? No. This is required in acute coronary syndrome. Spectrum, as I have already said, that is unstable angina, non-ST elevation MI and as well as the ST elevation MI. So, this is about your antiplatelet drugs. Then, next important group of drugs which are important in the treatment of ischemic heart disease will be the AC inhibitors, that is angiotensin converting enzyme inhibitors. In which group of patients the AC inhibitors are widely used? So they are widely used in the survivors of the myocardial infarction and in patients with hypertension or chronic ischemic heart disease including angina pectoris. We give this AC inhibitors. See, hypertension definitely we give because they are the antihypertensives, right? And they are also given in those individuals who are at high risk of vascular disease such as diabetes mellitus. See, in diabetes mellitus, the ACE inhibitor, diabetes mellitus with hypertension, the drug of choice will be the ACE inhibitors because they are renoprotective, right? And they also prevent the development of vascular pathology in diabetic individuals. So ACE inhibitors, they are widely used in the treatment of survivors of myocardial infarction. Number 2, hypertension patients, and number 3, diabetic patients, we preferably give this ACE inhibitors. Now, what is the benefit of giving this particular ACE inhibitors? The benefit is that the ACE inhibitors, the efficacy is most evident in ischemic heart disease. Okay, the benefit is more evident in patients with ischemic heart disease in reducing the mortality, right? And if patient is diabetic or if the patient is having left ventricular dysfunction, these ACE inhibitors, they have been found to reduce the mortality in patients with the left ventricular failure or left ventricular dysfunction, right? And those individuals who have not achieved adequate control of the blood pressure with the beta blockers, then we can add these particular ACE inhibitors where they are acting as the anti-hypertensive effect. So that is about the other group of drugs, that is the ACE inhibitors. Then we were discussing the drug which is given in case of chronic angina, that is the ranolazine. So ranolazine, it is an anti-anginal drug, and this, where is it derived from? It is a piperazine derivative, right? It is a piperazine derivative, and this is useful in the treatment of the chronic angina. And if you see the mechanism of action of this ranolazine, they inhibit the sodium current, right? They inhibit, I stands for inward sodium current. So they inhibit the inward sodium current. By inhibiting this inward sodium current, what is the benefit? The benefit is that this ranolazine will limit the sodium overload. It will cause the limitation of the sodium overload where within the ischemic myocytes, and it will also prevent the calcium overload within the ischemic myocytes. So it will cause the limitation of sodium and as well as the calcium overload in the ischemic myocytes. So thereby the depolarization and as well as the contractility within the myocytes will be reduced. So that is what is the action of your ranolazine. And the dosage of ranolazine is, it is given at a dosage of 500 to 1000 milligrams, right? It is given oral, and the frequency is, it has to be given twice daily, right? Whenever you give at this particular dose, they are very much tolerated. And you have to understand that this ranolazine, it is contraindicated in patients with the hepatic impairment. Don't give ranolazine in patients with hepatic impairment. And one more thing is, this ranolazine will cause the prolongation of the QT interval. So whenever you are supplementing ranolazine, you need to monitor the ECG for the QT prolongation, right? And they also should be avoided when you are giving the drugs which will inhibit CYP3A metabolic system. Okay, so drugs that inhibit CYP3A metabolic system, what are those drugs? Like example, ketoconazole, which is an antifungal agent, diltiazem, which is a non-dihydropyridine calcium channel blocker, verapamil, which is also a non-dihydropyridine calcium channel blocker, then macrolide group of the antibiotics like azithromycin, the HIV protease inhibitors, right? These protease inhibitors include sequinavir, indinavir, and as well as ritonavir, right? And large quantities of grapefruit juice. So these, they will inhibit CYP3A metabolic system. So whenever you are giving the ranolazine along with these particular drugs, that will further precipitate the adverse effects of the ranolazine. So that is the reason why ranolazine you should not give whenever you are giving these particular group of drugs. Okay, it is completely contraindicated. Now, next to the ranolazine, the other important drug that can be given that can reduce the mortality in patients with the ischemic heart disease is the SGLT2 inhibitors. The SGLT2 inhibitors, the example that you take is, one is dapagliflozin, right? And next is the canagliflozin, right? Next is the canagliflozin. So these are actually introduced for the management of the type 2 diabetes mellitus, right? But these drugs, they have emerged as important agents with cardiovascular and as well as renoprotective agents. So cardiovascular protective and as well as renoprotective efficacy is there with these SGLT2 inhibitors. These SGLT2 inhibitors, they promote the weight loss. That is one of the lifestyle modification what is required in ischemic heart disease, and they will reduce the blood pressure. So thereby they will reduce the afterload on the heart, and they will also reduce the plasma volume by inhibiting the SGLT2 channels at the level of the proximal convoluted tubule. So all these, weight loss, decrease in the blood pressure and decreasing the plasma volume, these are all required in patients with the ischemic heart disease, right? And not only that, these SGLT2 inhibitors, they also reduce intraglomerular hypertension. So by reducing the intraglomerular hypertension, the proteinuria can be reduced by your SGLT2 inhibitors. So evidence exists that they are helpful in patients with and without diabetes who have reduced LV ejection fraction. So in patients with reduced EF, you need to give this SGLT2 inhibitors. Whether the patient is having diabetes or without having diabetes, whenever you give these drugs in patients with reduced LV ejection fraction, they are found to improve the ejection fraction within the individual. So that is about your SGLT2 inhibitors. And one more group of, or one more drug that we have is the nicorandil. That is also the drug which will reduce the angina. But what is its mechanism of action? The nicorandil, if you observe, it is the potassium channel opener, right? So what it does, this nicorandil, remember, it is another class of agent that opens ATP sensitive potassium channel within the myocytes. So by opening the ATP sensitive potassium channel, what it does, it reduces the free intracellular calcium ions, right? It will reduce the free intracellular calcium ions, right? And the major drug in this agent that open the ATP sensitive potassium channel, what is that particular drug? That is nicorandil. So the route of administration is the oral route of administration. The dosage of this particular drug is, it has to be given 20 milligrams twice daily for the prevention of the angina. So that is about your nicorandil. So the other important drug which is given in the treatment of the chronic stable angina is the ivabradine. So ivabradine, if you see, it is the one which is given mainly to reduce the heart rate. So it is an SA nodal inhibiting agent, right? And in which group of individual it is useful is, it may be helpful for reducing the cardiovascular events. And the dosage of ivabradine is 2.5 to 7.5 milligrams, and the route of administration is the oral route of administration. It has to be given twice daily. And this particular ivabradine, it will prevent the cardiovascular events in patients with the ischemic heart diseases. Okay. And what should be the heart rate at which this ivabradine should be given is at a resting heart rate of more than or equal to 70 per minute, the ivabradine should be given. Okay. And this ivabradine, when you are giving, either you can give it alone or it can be given in combination with the beta blocker. Okay. And one point you have to understand and remember is that whenever you are giving this ivabradine, the LV systolic dysfunction, even if it is being present, you can give this ivabradine. But ivabradine should be given only whenever there is regular rhythm. Okay, if the patient is having sinus tachycardia, then ivabradine can be given, which will reduce the heart rate. But you cannot, there is no use of ivabradine given in case of the irregular rhythm like atrial fibrillation. In atrial fibrillation, it will not reduce the heart rate. It will reduce the heart rate only when the rhythm is the regular rhythm or it is a sinus rhythm. Okay, right. So, but it can be given in patients even with the LV systolic dysfunction as well, right? And the point is the development of the heart failure. So that was about your ivabradine, right? That finishes ivabradine. The point is the development of heart failure in patients with the ischemic heart diseases. If the ischemia is so severe, the same ischemic heart disease will go into a state of LV failure. So transient LV failure with angina, it can be controlled by the usage of the nitrates, right? And what these particular nitrates does, these nitrates, as we have discussed previously also, it will reduce the venous return, right? And thereby the LV wall tension can be reduced by your nitrates. See, what is the reason why the ischemic patients are going into a state of the LV failure? The mechanism or the reason is that for patients with established congestive heart failure or in patients with the ischemic heart disease, there is increase in the LV wall tension, and this increase in the LV wall tension will increase the myocardial oxygen demand, right? Will increase the myocardial oxygen demand. So once there is increase in myocardial oxygen demand, and at the same time the supply is not being adequate for a longer period of time, the individual will go into a state of the heart failure. So now whenever you are treating the congestive heart failure, so treatment of congestive heart failure reduces the heart size. Treatment of heart failure reduces the wall tension. Treatment of heart failure will reduce the myocardial oxygen demand. Okay, so remember, treatment of congestive heart failure helps in controlling the angina and as well as controlling the ischemia. That is the advantage of giving nitrates whenever the individual develops the congestive heart failure. The other group of drugs that you have to give whenever the individual develops congestive heart failure is the supplementation of the beta blockers. Okay, so the beta blockers, they will not only reduce the anginal episodes, right? The beta blockers, they are also given in the treatment of the heart failure, and they will reduce the mortality in patients with the congestive heart failure. That is the advantage of beta blockers. Nitrates, they have not been shown to be efficacious in reducing the mortality, but beta blockers, they reduce the mortality in patients with the congestive heart failure, right? And there was a trial of supplementing intravenous ultra short acting beta blocker, that is the esmolol, right? This has been found to be useful to establish the safety of the beta blocker in selected patients. So which beta blocker can be preferred is the intravenous ultra short acting beta blocker like esmolol can be preferred once the individual develops the heart failure. And next important is these beta blockers, they also have been found to reduce the nocturnal angina as well. Nocturnal angina often can be relieved by the treatment of the heart failure whenever you are supplementing the beta blockers. So in what way? See, during night, what happens when the individual is lying down in supine position, the venous return increases, the LV load increases, LV end diastolic volume increases, so LV wall stress increases. But whenever you are giving beta blockers, what these beta blockers will do? These beta blockers will reduce the myocardial stress by blocking the beta 1 receptors. Okay, so nocturnal angina often can be relieved by treatment of the heart failure, right? So the combination, if it is present in a patient with ischemic heart disease, right, in patient with ischemic heart disease along with angina, if there is development of congestive heart failure also, that indicates the patient is having poor prognosis, right? That indicates the patient is having poor prognosis. And whenever both of these are present, that is a mandate that the patient has to undergo the coronary revascularization, right? The patient has to undergo the coronary revascularization. So that is what is required whenever the patient is having both angina and as well as the heart failure. Now let me discuss about the coronary revascularization, which is a very, very important part of the treatment. So if you take this coronary revascularization, you have to remember that before going into a state of requirement of coronary revascularization, you need to initiate the medical management in patients with the chronic stable angina. So in chronic stable angina, the first important treatment is the medical management. And if the angina is refractory or like the patient developing congestive heart failure, then the individual require the coronary revascularization. So if you take the indications of the revascularization, number one, unstable phases of the disease. That means stable angina going into a state of unstable angina where the individual is developing angina at rest. Then it's an indication for revascularization. Intractable symptoms, that means refractory to medical management, giving beta blockers, giving nitrates, giving ranolazine, giving nicorandil, but still the angina is not subsiding, then it's an indication for revascularization. High risk coronary anatomy, right? The patient is having 2 vessel or 3 vessel disease, and that too significant stenosis is there. That's an indication for revascularization. Ischemic heart disease in diabetic patients, and ischemic heart disease associated with impaired left ventricular function where there is systolic or diastolic dysfunction, right? Systolic or diastolic dysfunction. So that is an indication for revascularization. Okay, so what is important in the treatment is, one, revascularization should be done in conjunction with the medical management. Not only giving the medical management, also you need to modify the risk factors that will contribute to the development of the ischemic heart disease. What are those risk factors? Like diabetes mellitus, hypertension, dyslipidemia, obesity. These are all the risk factors which will progress the individual to go into a state of ischemic heart disease. Even those risk factors have to be treated in these individuals. So I'll just give you an algorithm of the treatment of patients with ischemic heart disease, which is a table directly from Harrison. So you see this table. First and foremost, initiate the medical therapy, right? That is decrease demand ischemia, that is by giving nitrates or the beta blockers. Minimize the ischemic heart disease risk factors, that is treatment of diabetes, hypertension and dyslipidemia, and antiplatelets, aspirin or clopidogrel should be given, right? Now, you need to look for if there is any presence of the high risk features, right? Like, is there any low exercise tolerance or low exercise capacity? Or if the ejection fraction is less than 40%, or if the patient is having acute coronary syndrome type of presentation. So if the answer is no for all these, then the next important question that you need to ask the patient is, exertional symptoms, are they present or absent? Okay. So if the exertional symptoms are present, then continue the medical therapy, right? But the point is, if the patient is having exertional symptoms not responding to medical management, then in such case, you need to refer the patient to the coronary angiography. Then you need to plan for the revascularization. So when is that you need to plan for revascularization? Low exercise capacity, ejection fraction less than 40%, acute coronary syndrome type of presentation. In all these scenarios, you need to refer the patient to the coronary angiography and you need to plan for the coronary revascularization, right? Then, if it is a single vessel disease or left main with multi-vessel disease, right? Mainly single vessel disease, preferable is PCI. But if there is left main with multi-vessel disease, the preferable is CABG versus percutaneous coronary intervention. It all depends upon the surgical prohibitive risk of the individual. If the individual is having surgical prohibitive risk, then PCI is preferred if there is left main with multi-vessel disease. If the surgical prohibitive risk is not there, then CABG is being preferred. Okay. So this is about the algorithm of management of patients with the chronic stable angina. So now let us discuss first about the percutaneous. Let us discuss first about the percutaneous coronary intervention and then we'll move on to the discussion of the CABG. See, percutaneous coronary intervention, what does it involve? It involves the balloon dilatation of the stenosed vessel. Followed by that, you need to place a stent. These days, what are being used is the drug-eluting stents are being used, right? So, ballooning and as well as the coronary stenting, these two, they are widely used to achieve the revascularization, right? They are widely used to achieve the revascularization of the myocardium, right? And this particular revascularization by percutaneous coronary intervention should be done in patients who are having suitable stenosis of epicardial coronary arteries. What will be that suitable stenosis of epicardial coronary arteries? I will discuss that, right? Then, so which group of individuals CABG is best preferred? Which group of individuals PCI is widely employed? So CABG is preferred in if there is left main coronary artery stenosis. Along with that, there is triple vessel disease, that is stenosis in left anterior descending artery, stenosis in left circumflex artery, stenosis in right coronary artery, along with left main involvement. And the patient is also diabetic. Patient is also having impaired LV function. So in them, CABG is preferred. Whereas PCI is widely employed in patients with symptoms and evidence of ischemia due to stenosis of one or two vessels. Percutaneous coronary intervention can be comfortably done, right? And even in selected patients with triple vessel disease, you can go ahead with the stenting, that is percutaneous coronary intervention also, right? Now, let me discuss about the indication and as well as the patient selection for percutaneous coronary intervention. See, the most common clinical indication for PCI is symptom limiting angina pectoris. Symptom limiting angina pectoris, percutaneous coronary intervention should be done. That means the patient is having the symptom in spite of medical management. Despite medical therapy, the patient is having the anginal symptom, then you need to do PCI. Okay. Or if there is evidence of ischemia upon stress test, you have done a treadmill test, there is a significant ST segment depression which has developed, or you have done a dobutamine stress echo, there is new regional wall motion abnormality which has been seen, then in such scenario, better to do the percutaneous coronary intervention rather than medical management alone. But remember, if you compare PCI and as well as medical management, PCI is more effective than compared to that of medical therapy for the relief of the angina. And if you take few more indications and patient selection, PCI improves the outcome in patients with unstable angina or in early stages of myocardial infarction with or without cardiogenic shock. These are the other indications where PCI has to be done. In case of chronic stable angina, all the patients, they don't require percutaneous coronary intervention. But in all these patients with acute coronary syndrome, that is unstable angina and as well as myocardial infarction, they preferably require percutaneous coronary intervention. Even though the patient is having cardiogenic shock or not, the PCI is definitely indicated. And few more indications if you see, right? The PCI can be used to treat stenosis in the native coronary arteries, right? Or the PCI can be used if there is stenosis in the bypass grafts. And because of the stenosis of the bypass grafts, if there is recurrent angina, then PCI should be done in that particular bypass grafts as well. So these are the indications where you need to do percutaneous coronary intervention. Now, what are the risks associated with the percutaneous coronary intervention? See, whenever the coronary stenosis, if it is discrete and symmetric, right? If the coronary stenosis is discrete and symmetric, and if it is a two-vessel disease or single vessel disease, even though it is a triple vessel disease, but if the stenosis is discrete, that means localized to one particular area of the vessel, and if it is symmetric, that means throughout the vessel, the stenosis is there, even though the stenosis is present in a sequentially, right? That means, I'll just show you this, okay? So there is a stenosis here, right? And there is stenosis here. So even though stenosis is present in a sequence, but if it should be discrete and symmetric, then percutaneous coronary intervention can be done. But the problem is that, okay, so symmetric 2 and 3 vessel disease, you can go ahead with the PCI. But the complications with the percutaneous coronary intervention is that whenever you are doing stenting, there is a chance that you can do the dissection of the coronary artery. So coronary dissection or thrombosis is one of the important complication of your percutaneous coronary intervention. And once there is thrombosis, you know, the patient will develop uncontrolled ischemia and the individual will go into a state of the left ventricular failure. So this is one complication of percutaneous coronary intervention. Then how will you deal with this particular complication? If there is development of stent thrombosis secondary to dissection, immediately, right, you need to supplement the oral aspirin, or you need to give P2Y12 ADP receptor antagonist, and an antithrombotic agents are given to reduce the coronary thrombosis. Right, to reduce the coronary thrombosis. So this is what you need to do whenever the individual develops coronary dissection and as well as thrombosis. And what about this left main coronary artery stenosis? See, this left main coronary artery stenosis generally is regarded as a lesion that should be treated with the CABG. Usually, left main coronary artery stenosis, right, they are referred to the cardiothoracic surgeon for going ahead with the coronary artery bypass graft. But in selected patients where there is prohibitive surgical risk, then percutaneous coronary intervention of left main coronary artery stenosis can also be done. But whenever you are doing this stenting of left main coronary artery, that has to be performed by highly skilled operator, because whenever you are doing stenting of left main coronary artery, what is that you will be doing initially? You will be doing ballooning of the vessel. So when you do ballooning of the vessel, you will be blocking LAD and as well as LCX. The ischemia and infarction can get precipitated. So in order to avoid that, they have to be undergone by a highly skilled operator to prevent that particular ischemic or the infarction. Okay, then so if you take the efficacy of this PCI, as I have said you, it is definitely better compared to medical management. The primary success with relief of angina is achieved in more than 95% of cases, right? In more than 95% of cases, right? Now, what about the recurrent stenosis? The recurrent stenosis, it is more common with the bare metal stents, right? So, recurrent stenosis of the dilated vessels, it occurs in almost 20% of patients. Okay, recurrent stenosis of the dilated vessels occurs in 20% of cases within 6 months of PCA, right? Within 6 months of PCA, mainly when you are using this bare metal stents. And the development of angina, it will recur within 6 months in 10% of cases. Okay, so recurrent stenosis will occur in 20% of cases within 6 months of PCA with bare metal stents, and recurrence of angina will occur within 6 months in 10% of cases. Now, what are the risk factors for the development of the recurrent stenosis? So, the restenosis, it is more common in diabetic patients, more common in arteries with small caliber, and whenever you are doing dilatation of the vessel, if incomplete dilatation of the stenosis is being done, there is high chance of the recurrence. And when you are using the long stents, there is high chance of the recurrent stenosis. And if the vessels are occluded, and if there is obstructed vein grafts you are using for the grafting, dilatation of left anterior descending artery not being done properly, right, then stenosis containing the thrombi. So these are all the reasons why there can be recurrent stenosis, right? And one point, whenever you are using the grafts, vein grafts for CABG, if they are diseased, so diseased vein grafts, whenever you are using, what you need to use is, you need to use a distal protection device. Okay, so you can just see here, right, this is a distal protection device. So this particular thrombus, whichever is there, there is a high chance that they can go as a form of emboli into the distal part of the circulation whenever you are using the diseased venous grafts. So this diseased venous grafts, when you use the embolic protection device, this particular emboli, whatever is this thrombus, once it embolizes, it will enter into this particular protection device, and this particular protection device is removed after stenting of the graft. Okay, so in diseased vein grafts, procedural success has been improved by use of capture devices or filters that prevents embolization, that prevents ischemia, and as well as the infarction. So distal protection devices are very, very important, mainly to prevent the embolization to the distal circulation. So in order to avoid these particular restenosis, these days what have come up is the drug-eluting stents. See, these current generation drug-eluting stents, they deliver, or it has the anti-proliferative efficacy, right? So in the drug-eluting stents, the drug what we use is the sirolimus, everolimus. These drugs, they have anti-proliferative efficacy, and they can reduce the stenosis to less than 5%. See, the chances of restenosis with bare metal stents were almost 20%, but here the chances of restenosis is reduced to less than 5%, right? But of note, delayed endothelial healing, right? Delayed endothelial healing in the region of a drug-eluting stent, that has been found to be associated with risk of subacute, it has been associated with risk of subacute stent thrombosis. Okay, why is this subacute stent thrombosis? That is because of delayed endothelial healing in the region of a drug-eluting stent. Okay, now In order to avoid these particular restenosis, or in order to avoid this thrombosis of the stent, you need to give dual antiplatelet therapy. That is, you need to give aspirin. Along with that, you need to give clopidogrel. For how long you need to give these drugs? That is for nearly around 12 months. Okay, that is for 1 year you need to give. But some studies have shown the benefit of giving this DAPT for up to 30 months as well. But only the problem is, whenever you are giving DAPT for 30 months, there is higher risk of bleeding. So that is one important adverse effects whenever you are giving for longer duration dual antiplatelet therapy, right? Then next important is, apart from this dual antiplatelet therapy, we have some new anti-thrombotic regimens which have been introduced mainly to avoid the DAPT for up to 1 year. Now, what are those regimens? Those regimens include shortening the duration of DAPT by eliminating the aspirin. Okay, so you stop aspirin after 3 months, right? Stop aspirin after 3 months and continue a potent P2Y12 ADP receptor antagonist, that is ticagrelor. The remaining part of the life, continue with the ticagrelor. That is one new antithrombotic regimen. Previously, what we were giving, aspirin and clopidogrel 12 months. The new regimen is give aspirin only up to 3 months, then stop, along with ticagrelor. And after 3 months after stopping aspirin, you just continue only ticagrelor. This because this ticagrelor is a highly potent antithrombotic agent. That is one regimen. The other regimen is switching the DAPT to dual pathway inhibition. What is the dual pathway inhibition? One pathway of inhibition is the antiplatelet, by which thrombus formation can be prevented. The other pathway of inhibition is low dose direct oral anticoagulation. Okay, this low dose direct oral anticoagulation which are being given in the recent days are dabigatran, apixaban, endoxaban. These are being given, and these are particularly attractive options for ischemic heart diseases in patients with atrial fibrillation. So in patients with atrial fibrillation with ischemic heart disease, it is preferable to give this low dose direct oral anticoagulants. Okay, right. So these are the two new antithrombotic regimens. One, aspirin and ticagrelor for 3 months. After 3 months, only ticagrelor. The other one is switch the DAP2 to dual pathway inhibition, that is antiplatelet and as well as low dose direct oral anticoagulation, right? Then now one point you need to remember is that whenever you are doing a successful PCI avoids the risk of stroke associated with the coronary artery bypass graft. Okay, so this CABG, it is associated with increased risk of stroke, but the PCI, it has lesser chance of development of stroke development, right? And another advantage of the PCI over CABG is that this PCI, it also allows earlier return to work and resumption of the active life. But CABG, morbidity will be there for a longer period of time because the patient will undergo that sternotomy, right? Now, when you compare the CABG versus PCI, right, in which scenario CABG is superior to that of PCI, right? The two advantages of PCI we have discussed is PCI will reduce the incidence of stroke, PCI will reduce the morbidity, right? Immediately the patient will go into a state of active life with PCI. But the scenarios where the CABG is superior over the PCI is when directly compared in patients with diabetes or 3-vessel disease or left main coronary artery disease. In all these scenarios, CABG is superior to percutaneous coronary intervention, right? So if you take a 12 months follow-up in these patients, this particular patient with diabetes or 3-vessel disease or left main disease, one set you go ahead with the PCA in one set of patients. In another set of patients, you go ahead with the CABG, which has been found to be highly efficacious. Is the CABG is efficacious in these group of individuals. So if you take the coronary artery bypass grafting, what does it includes? It does the anastomosis of the internal mammary artery, either one or both of the internal mammary artery, or it does the anastomosis of the radial artery to the coronary artery distal to the obstructive lesion, right? So either we anastomose directly the internal mammary artery to the distal part of the obstruction, or we anastomose the radial artery to coronary artery distal to the obstructive lesion. So that is what we do in the coronary artery bypass grafting. Okay, you see here. So see, this is actually the venous graft, but which grafts are preferable is the arterial grafts are more preferable than compared to that of the venous grafts. Why? I will tell you. So you can just see here. So this is the lesion in the coronary artery. So distal to the lesion, you need to place the graft, right? And if you take this particular grafts, as I have said you have the venous grafts and as well as the arterial grafts. Okay. So the venous grafts, what are the types of venous grafts we use? That is the saphenous venous grafts. That is what we use. Okay. And these venous grafts, they form a venous bypass conduit between the aorta and as well as distal to the lesion in the coronary artery. Okay, so that is what the saphenous vein does. It will bypass the area where there is lesion, right? Now let me tell you what are all the indications of the CABG. So although some indications for CABG are controversial, certain areas of agreement definitely exist for CABG. Now, what are those areas where CABG are preferable than compared to that of your percutaneous coronary intervention? Those areas include, number one, first and foremost, the operation should be relatively safe, right? Or the operation is relatively safe with mortality rates less than 1%, and it should be done, the CABG should be done in patients without serious comorbidities, and the CABG should be preferably done in patients with normal LV function, where in order to have a very good outcome, even with impaired LV function also your CABG is preferred, but with normal LV function if you do, the efficacy is still more better. Okay, the recurrence of the angina or recurrence of ischemia will never occur, right? And when this particular procedure is being performed by experienced surgical team, remember this operation is being considered to be relatively safe with mortality rate less than 1% in patients without serious comorbid disease and normal LV function. Okay, that is one scenario. The another important scenario is the intraoperative and post-operative mortality rates. When do they increase? We want the mortality rate to be reduced less than 1%. But in certain scenarios, the mortality rates are high when the patient is undergoing CABG. What are those? A patient with severe LV dysfunction, where the ejection fraction is less than 30%, the chances of post-operative mortality rate is high. Patient having comorbidities like hypertension, diabetes, dyslipidemia, age, obesity, family history, right? So comorbidities are high, there is chance of the higher mortality, right? Age more than 80 years, lack of surgical experience. In all these scenarios, the chances of mortality is high. Now, I said you like the grafts, we use arterial grafts and we use the saphenous vein grafts. The chances of the graft occlusion with the venous grafts is more. What is the chance of that occlusion? So, if you take the occlusion of the venous grafts, that is observed in almost 10 to 20% of patients during the first post-operative years. Right? In the first post-operative year itself, it has been found that the graft occlusion is almost 10 to 20%. Right? And subsequently, the graft occlusion decreases. Now, this long-term patency are considerably higher for the arterial grafts, right? They are higher for the internal mammary arterial grafts and they are very high for the radial artery grafts. So, when compared to the arterial grafts, saphenous vein grafts, they have the higher tendency of the restenosis or the blockade. right? So in patients with left anterior descending coronary artery obstruction, survival is better when coronary bypass involves the internal mammary artery rather than the saphenous vein. Okay, and if you take the graft patency, what all it depends on? The graft patency, it depends on the risk factors of the individual, right? And it also depends upon particularly which particular risk factor, that is dyslipidemia. Okay, it mainly depends upon this dyslipidemia. And that is the third point. And fourth point is the angina is abolished or greatly reduced in 90% of patients after complete revascularization. Right? After complete revascularization, in 90% of the patients, the angina is abolished or greatly reduced. Okay. And the next point is survival may be improved by operation in patients with stenosis of left main coronary artery as well as in patients with 3 or 2 vessel disease with significant obstruction of proximal left anterior descending artery. So in this group of individuals, if you do CABG, there is significant improvement in the mortality after the operation. And you have to understand that the survival benefit is greater in patients with abnormal ejection fraction when the ejection fraction is less than 50%. When the LV ejection fraction is less than 50%, the survival benefit is greatest in these patients. Okay. Now, in the recent times, what type of CABG has been started is minimally invasive CABG. That minimally invasive CABG through small thoracotomy or off-pump surgery, right? Or off-pump surgery, they have been found to reduce the mortality. Right? They have been found to reduce the mortality and they have been found to shorten the convalescence in suitable patients, right? So, and one more point is in diabetic patients mainly. So, among patients with type 2 diabetes mellitus and multi-vessel coronary artery disease, CABG plus optimal medical therapy is superior compared to that of optimal medical therapy alone. Right? So these are some of the very important points related to the CABG. Now, one point you have to know is that what are the parameters which are present in the patient will increase the higher or will increase the perioperative mortality rate, right? So if the patient is in a state of congestive heart failure or LV dysfunction, age of the individual more than 80 years, requirement of reoperation, urgent need for surgery, and the presence of diabetes mellitus, all of these are associated with a very higher perioperative mortality, right? All of these are associated with a very higher perioperative mortality rates. Okay, and you take in scenarios of the hibernating myocardium. What is hibernating myocardium? Hibernating myocardium is that there is LV dysfunction. Why there is development of LV dysfunction? That is because of the chronic ischemia. So LV dysfunction can be due to non-contractile or hypocontractile segments that are viable but are chronically ischemic, right? So they are viable. It is not the dead myocardium. And that form of myocardium is called as the hibernating myocardium. So hibernating myocardium means viable myocardium, but they are non-contractile. Why they are non-contractile? Because they are chronically ischemic. So as a consequence of chronic reduction in the myocardial blood flow, these segments downregulate their contractile function. That is the reason why they are non-contractile or hypocontractile and they are considered to be the hibernating myocardium. So now, these, how can you detect? How can you detect the presence of the hibernating myocardium? the presence of the hibernating myocardium, the presence of that viable myocardium, the presence of hypocontractile or non-contractile myocardium, they can be detected by using radionuclide scans of the myocardial perfusion and as well as the metabolism. Now, what are those myocardial perfusion scans or radionuclide scans? That includes positron emission tomography, that includes the cardiac MRI or delayed scanning with thallium 201 or dobutamine stress echo. These are the various ways by which you can assess the hibernating myocardium, right? Now, what is the importance of detecting that hibernating myocardium? In those patients with hibernating myocardium, when you do revascularization improves the myocardial blood flow and revascularization improves return to the normal function, right? Return to the normal function. Okay, so that is what is the advantage of the revascularization, right? And this particular revascularization will also improve the survival in patients with hibernating myocardium, right? So that is about whether to do the revascularization in hibernating myocardium or not. You have to do it. Now, when you take the choice between PCI and as well as CABG, right, which is preferred? You take any patient, either you take single vessel disease or two vessel disease or three vessel disease or left main, right? If you take the choice between the PCI and as well as the CABG definitely, it's like a cumbersome procedure, right? Where perioperative morbidity is more than compared to that of mortality, right? But if you take the choice between the PCI and as well as the CABG, all the clinical characteristics of each individual patients must be used to decide on method of revascularization. What are all the parameters that you need to take into consideration to decide between PCI and as well as CABG? That includes, is there any presence of the LV function, right? If there is severe LV dysfunction where the ejection fraction is less than 30%, preferable to go ahead with the PCI. Diabetes mellitus, diabetics preferable to go with the CABG. And the decision also depends upon the lesion complexity as well. So these are some of the things which will decide whether to go ahead with the PCI or the CABG. And what has been found is a number of randomized clinical trials have compared PCI and CABG in patients with multi-vessel diseases who are suitable for both the procedures. In multi-vessel diseases, which one to go ahead, whether it is PCI or the CABG? What has been found is the redevelopment of angina requiring repeat coronary angiography and repeat revascularization was higher with PCI. Okay, in multi-vessel disease, what is that you want better treatment? The studies have shown that with PCI, there is redevelopment of angina, there is redevelopment of stenosis. So in multi-vessel disease, preferable to go ahead with the CABG, right? And this repeat angina is due to what? Just now we are discussing, that is due to restenosis in the stented segment. And not only that, if you see this image, what the PCI does, is PCI will target only the culprit lesion, right? It will target only the culprit lesion, but the PCI may neglect this future culprit lesion. Thereby, this future culprit lesion will be the lesion for re-requirement of the PCI again. That is what is the problem with the PCI. It targets only culprit lesion. It will neglect the future culprit lesion. But the advantage of the CABG is that we place this bypass graft distal to the future culprit lesion. That is the reason why re-requirement of revascularization is not required in whenever you take up with the CABG. But re-requirement in multivessel disease of your revascularization is more whenever you do the percutaneous coronary intervention. But the only advantage of percutaneous coronary intervention is the stroke rates. It is less with PCI than compared to that of the coronary artery bypass graft. Okay, so this is about your CABG and as well as the percutaneous coronary intervention, right? So at the end of the story, in patients with multivessel diseases, preferable to go ahead with the CABG, right? Then apart from this, we have some unconventional therapies for ischemic heart diseases. Now, a patient who has persisting disabling angina despite maximally tolerated medical therapy and for whom revascularization is not an option, then what are the other conventional therapies, right? Now, what are the reasons why revascularization cannot be done in some of the group of individuals? Example, like small, diffusely diseased vessels which are not amenable for stents, or the small diffusely diseased vessels, they don't have the acceptable targets for bypass grafting. In this scenario, what are the unconventional treatments for ischemic heart disease? These unconventional treatments include the enhanced external counterpulsation techniques, EECP. What this does, so in which group of individuals you are doing this unconventional treatment options? Those patients with ischemic heart disease where you have given maximal optimal medical management, but they are not fit for CABG or PCA. In them, you need to plan for this EECP. What it utilizes? It utilizes the pneumatic compression devices. These are the pneumatic compression devices, okay? These pneumatic compression devices, they are placed over the lower extremities. What do they provide? They provide diastolic augmentation and diastolic oxygen consumption into the coronaries. So basically what these devices do, they are being programmed in such a way that during the diastole of the heart, these devices, they compress. So thereby it will increase the venous return and thereby it will increase the diastolic filling during the diastole of the heart. So thereby, even though there is stenosis, because of increase in the flow during the diastole, the myocardial perfusion can increase and angina can be reduced. So this is one of the unconventional approach where the revascularization cannot be done, right? So the clinical trials have shown that regular application of this particular EECP have been found to reduce the angina. It has been found to improve the exercise capacity, right? And it has been found to improve the myocardial perfusion. Okay, so that is what the clinical trials have been shown about the EECP. And we have some experimental approaches which are coming up. The new approaches which are coming up are the stem cell therapies, right? And cardiac repair with small non-coding RNA molecules that we call it as miRNA. Okay, cardiac repair with small non-coding mRNA molecules. So these are under active study. So this is about the unconventional approaches by which you can treat the ischemic heart diseases, those individuals not fit for PCA or CABG. Now, next to this, we have a clinical entity called as the asymptomatic silent ischemia. What is this? Let me discuss. So, if you see this asymptomatic silent ischemia, so patients with obstructive coronary artery disease, patients with acute myocardial infarction, and patients with transient myocardial ischemia, right? They can occur in the absence of symptoms, right? So the individual will not have chest pain, but the individual will be having underlying coronary artery disease, underlying acute myocardial infarction or transient myocardial ischemia. But the chest pain is not there. That is what is nothing but asymptomatic silent ischemia. Now, how can you detect these patients, or how will you diagnose these patients? So what you need to do is, you need to do ambulatory ECG monitoring. See, these patients, they have active life outside the hospital. The activity is good for these individuals. But when you do this ambulatory ECG monitoring, whenever the ischemic events are there, or whenever the typical chronic stable angina occurs, the ECG will show the ST segment depression. So, during the episodes of ischemia, there is ST segment depression when you do ambulatory ECG monitoring in these patients. So, this is how you can pick up the asymptomatic or the silent ischemia. And one point you have to remember is that many of these patients, they also have more frequency of the episodes of the asymptomatic ischemia. Now, as the frequency increases, what will be the problem, right? Many of the times, right, they'll be having the asymptomatic ischemia, but there is no chest pain. Now, the point is, whenever the frequency increases, the frequent episodes of the ischemia during daily life appear to be associated with increased likelihood of the myocardial infarction. Okay, so from the state of chronic stable angina, the individual will progress to a state of myocardial infarction if there is frequent episodes of the ischemia, right? And you have to remember that in addition, patients with asymptomatic ischemia, after a myocardial infarction, they are at increased risk, right? They are at increased risk for secondary coronary event, right? They are at increased risk for secondary coronary event. So these patients, right, they are asymptomatic. They don't realize that they are having an underlying ischemic events which are going on. So these patients, after myocardial infarction, they are at greatest risk of the secondary coronary event as well, right? Now, the widespread use of the exercise ECG. So how can you detect these patients? Apart from ambulatory monitoring, the widespread use of exercise ECG during routine examination that have identified some of these patients, okay, that have identified some of these patients with asymptomatic coronary artery disease. So this, now in which group of individuals we do this particular exercise stress testing? In those individuals who are having risk factors, diabetic patients, elderly individuals, having dyslipidemia, having hypertension. So those individuals with risk factors, we need to expose them to the exercise ECG, right? This will show you the presence of an underlying ischemia, right? Once the test is positive, right, we need to consider that there is an underlying ischemia that is going on. And if you take the management of patients with asymptomatic ischemia must be individualized, right? That is, when the coronary disease has been confirmed, the aggressive treatment of the risk factors are very, very important. That is, the aggressive treatment of hypertension, aggressive treatment of dyslipidemia is very much essential. Once you treat these risk factors, they will reduce the risk of the infarction and they will reduce the risk of development of death within the individual, right? And remember, asymptomatic patients with silent ischemia, 3-vessel disease and impaired LV function may be considered appropriate candidates for coronary artery bypass graft. These patients, they have to undergo the CABG, right? And apart from that, as I have said you, the treatment of the risk factors, particularly lipid lowering agents and blood pressure controlling drugs have to be supplemented, okay? That is beta blockers and as well as the statins and antiplatelet drugs, that is aspirin, should be supplemented in these individuals, okay? And how can you reduce the incidence of the asymptomatic ischemia? The incidence of asymptomatic ischemia can be reduced by treatment with beta blockers can be reduced by giving calcium channel blockers, by giving long-acting nitrates. So, by giving these particular drugs, the incidence of asymptomatic ischemia progressing to myocardial infarction can be reduced. So, this is about asymptomatic ischemia. So, asymptomatic ischemia means the patient is having the underlying ischemia, chronic stable angina, or the myocardial infarction, or acute coronary event, but the individual does not have the chest pain. These patients, they are considered to be very dangerous. They may go into a state of sudden cardiac death. Okay, so this is about the treatment of the chronic stable angina. So in the treatment, like we have discussed, lifestyle modification, that is diet and as well as the adaptations, medical management, that should be the first line treatment for chronic stable angina, then revascularization methods, that is by your CABG or percutaneous coronary intervention. So which group patients require PCA, which group patients require CABG, what are the advantages of PCA and CABG, all that we have discussed in the treatment of chronic stable angina. So with this, I'll wind up this session. Thank you very much.